All right. So as an introduction, so basically injuries have been used classically to differentiate between epileptic seizures and functional seizures or psychogenic non-epileptic seizures or events. And basically part of our history, when we see a patient or when a resident presents a patient to us, we ask about tongue biting, falls or injuries or urinary incontinence as part of the history taking. And it's been long considered to be a typical sign of epileptic seizures. But basically, functional seizures can also have these signs. They can have tongue bite, they can have also falls, and that actually can be misleading for physicians, and it actually can delay the diagnosis of functional seizures. This has been studied in a paper in 2002 by Timari et al. And it actually mentioned the delay in the diagnosis because of the history reporting of tongue biting and falls. Now, tongue biting has been studied in functional seizures. The prevalence is about 25%. That's a study by Brigo et al. From 2012 in Epilepsy and Behavior. And the next question we ask if somebody has a tongue bite was whether it was a lateral tongue bite or a tip of the tongue bite. And typically patients with functional seizures, they have tip of the tongue bite with virtually not zero lateral tongue biting. And this was also reported in this study. Now, lacerations, fractures, burns, or bruises have yet to be included in any systematic review. And this study or systematic review aimed to answer this question: what is the overall prevalence of seizure-related injuries or ictal injuries in patients with, or specifically adults with, functional seizures? They used basically the PICAS acronym for inclusion criteria, with population defined as adults with the age of 18 and older, with a diagnosis of functional seizures with any comorbidity, including epilepsy, with exposition of physical injury resulting from a functional seizure. And this was basically defined as damage inflicted on the body or without disruption of structural continuity as the direct result of a functional seizure. And there were no comparison, and the outcome was basically the prevalence of physical injuries resulting from a functional seizure. This study designed was an observational study. One thing that was kind of interesting for me is that basically video EEG was not a mandatory inclusion criteria for functional seizure diagnosis. All right. So basically, they screened or collected and identified about 2,607 studies basically from PubMed, Scopus, Web of Science, etc. And they removed the duplicates. They screened about 2,119 records or studies, and they excluded most of them. They were left with 61 records that they assessed eligibility for, and these studies finally included were 41 in the qualitative synthesis, and in the meta-analysis they included 28 studies. Now, talking about the results, all articles were observational studies, and they were conducted in about 20 different countries all over the globe. And the sample size of each study ranged from 10 to 509, and specifically for functional seizures between 17 and 369. They included in this analysis patients with functional seizures alone, patients with functional seizures and comorbid or co-concurrent epilepsy, so functional seizures and epilepsy in the same patient, and another group of patients with both. They compared or studied also both functional seizures only and functional seizures with concurrent epilepsy, and this was defined as the mixed group. Now, the injuries reported in these studies were ictal injury at any time since the onset of the seizure. So that was defined as the lifetime prevalence, and also or the occurrence of ictal injury during a period of time. And this was basically in the results defined as the period of time when the patient was on EEG. Video EEG. Now, the studies used questionnaires or interviews to investigate the previous history of ictal injuries related to functional seizures. And this was defined as the lifetime prevalence, which was also studied. And for the period prevalence, so patients who were on EEG and were assessed for history of injury in the setting of a seizure or functional seizure, they used physical examination to investigate the presence of ictal injuries immediately after the event itself. Now, I'm not going to talk a lot about each study because we have a lot of them that was reviewed, but basically these are listed in alphabetical orders. And as we see here, we have a range of numbers. Some included 230, other included like less than that. And the number of the different type of injuries basically were predominantly tongue biting, tip of the tongue bite, ictal injury, tongue injury, laceration, burn, bone fracture, tooth injury, head injury, shoulder injury, dislocation, and basically they did not really report except for a few burns, but they did not really analyze the with patients who had a functional seizure, what was the prevalence of each injury in each patient. This is the other subset of articles that they reviewed, also listed in alphabetical orders. Also, it includes the same type of injuries that I already mentioned: tongue laceration, cheek biting, and that's the third subset, which also included a tongue biting and even TBI. I don't have a specific definition of TBI, how they define it, but this was also reported in here. But as we see here, that the main injuries that were focused on are buccal or oral injuries, and less. We don't see much of burn reported in these from these studies. Now, for the lifetime prevalence of ictal injuries per person with functional seizures, they did a meta-analysis of 13 studies, and they analyzed about 1,673 participants or patients. And the overall lifetime prevalence for functional seizure per person was about 25%. And when they studied the subgroup analysis with functional seizure only subgroup, it was about 24.16%. The mixed subset was 28.01 or 28%. And for the functional seizure and the epilepsy subgroup, so patients who have both, they have about also about 25% or 24.6%. So this is the meta-analysis, and as you see, the overall was about 24.8% risk of lifetime prevalence of ictal injuries per person with functional seizures. Now, they also studied the period prevalence of ictal injuries per person with functional seizure. And they also did here a meta-analysis of 13 studies with 848 participants. And the overall prevalence or overall period prevalence of injuries due to functional seizure per person was low, was about 0.7%. But we're going to keep in mind that some studies had high level of bias and they were excluded, which I'm going to come and discuss further in other slides. Now, the period was defined as when the patient was on video EEG setting or like recorded, and it ranged from 1 hour to up to even 37 days. And the subgroup analysis, they found when they studied the functional seizure only group, it was about 0.23% for period prevalence of ictal injury per person with functional seizure. For the mixed subgroup, they had about 6.45%, but for patients who had functional seizures and epilepsy, it was about 0%. Oops. Again, this is the figure of the meta-analysis graph. And as you see, the overall prevalence of period prevalence of ictal injuries per person with functional seizure was about 0.7%. Now, the last prevalence they studied was basically the period prevalence of ictal injuries per number of functional seizure, another term that the injury per seizure. And basically, they studied here, the meta-analysis was on 8 studies only with 1,000 participants, and it was found to be about 0.1%. The prevalence of injuries due to functional seizure per functional per seizure was about 0.1%. And this also shows the meta-analysis graph with the overall prevalence of injury per number of functional seizure was about 0.1%. Now, so basically when they looked into the studies, first talking about the lifetime prevalence of ictal injury per person with functional seizures, there was these were basically observation studies, all of them, and the risk of bias in these studies was serious. And basically because of a presence of bias in the methodology of the studies. And there was also very serious inconsistencies, which were also defined as substantial heterogeneity between the studies. And there was lots of the high level of imprecision. Sorry about that. And basically, even though the rate was about 25%, but you see how the confidence interval and the level of certainty of evidence was very low. So I don't think we can really conclude that patients with functional seizures have a prevalence of lifetime injury of about 25%. But basically the same thing for the period prevalence of ictal injury per person with functional seizure. The risk of bias was serious. The inconsistencies were serious, and the rate that was concluded from this analysis was the level of certainty of evidence was low. The same thing for the period of prevalence of ictal injury per number of functional seizures. It was about 0.1%. It had a higher level of evidence or certainty of evidence compared to the other prevalences studied. Now, again, after they addressed the potential bias and they removed or excluded high-risk bias studies, 5 of them, and the moderate risk bias studies, 9, which are 29 of these studies. When they reassessed the overall period prevalence of injury per person, it was found to be 0 in the meta-analysis. Now I'm going to move to the discussion now. According to the authors and to the literature, this is the first systematic review to review and evaluate functional seizure-related injuries during video EEG monitoring. And basically, the types of injuries that were reported and focused on here were mainly buccal injuries, tongue injuries, cheek injuries, lip biting, or fractures, lacerations, dental injuries, bruises, and head injuries. We do not have an exact prevalence of these injuries based like the cumulative or like analysis of the of this review of each single each single injuries in patients with functional seizures. Now, the studies with video EEG monitoring have only reported the occurrence of oral lesions. They did not, in this study, include some prior studies that reported pillow asphyxiation and falls in patients with functional seizures. So basically, in this study by Atkinson in 2012, with about 116 patients with functional seizures, they found about 2.6% and had injuries like pillow asphyxiation and falls. They also did not include a study that reported cyanosis in patients with pseudo, at least that was in 1989, what used to be called pseudostatus epilepticus. And this study was not also included. So it was basically more oral injuries. Now, based on the studies and the study, but basically that's something we all know, that video EEG is pretty safe for patients with functional seizures and patients with epilepsy. Obviously, patients with epilepsy, when they have generalized tonic-clonic seizures, they might be at high risk of injury, but we all know that, but this was also one of the conclusions or discussion points. Now, the lifetime prevalence rate for injuries per person is similar to prior studies in the past, but basically they compared here their findings to the study by Brigo et al., which found about 25% of tongue injuries, again, tip of the tongue injuries in patients with functional seizures. And again, the main focus was here on oral injuries. And they also found that the lifetime prevalence of injuries was similar between the three subgroup samples. Now, some of the limitations. So this is a retrospective study. There are heterogeneous data sets. There's diverse age groups. They excluded patients who are like pediatric patients, but still there was a huge age, range of age groups. And the studies that reported the occurrence of injury without specifying the type did not really provide a definition of injury. So there's some bias here, there's some uncertainty. And all studies were composed of convenience sample from highly specialized healthcare centers, which makes it a bit of a limited to generalize the findings here. Now, there is no comparison of prevalence of injuries with other groups, such as patients with epilepsy alone. So all patients were only functional seizures or functional seizures and epilepsy together. Some conclusions. So in summary, the key points, but keeping in mind the low levels of incidence and the high level of uncertainty, based on the findings from the study about the prevalence of lifetime injury in patients with functional seizures is about 25%. Again, this was, there's low evidence or like certainty. The injuries during video EEG is about 0.7%, and per seizure, functional seizure, it's about 0.1%, based on this study. Now, despite the limitations in this study, I think one conclusion is that the fact that epileptic seizures, we know that pose a high risk for injury compared to functional seizures. We should not really exclude functional seizures from the differential diagnosis if suspected. So if a patient presents with a semiology by history that is not really typical of epileptic seizures, I don't think we should be biased if we hear that there is a burn or there is a tongue bite or there is another type of injury. We should still proceed and pursue, if needed, a video EEG, have like the correct diagnosis to avoid unnecessary treatment and prolonged misdiagnosis of the patient. And we see this in real life. So I'm gonna stop here because I would go over quickly another article which is a bit related to that. I'm gonna stop here for questions or comments before I move on to the other article I would like to cover quickly. I guess no questions, comments. I mean, one of the things in my conclusions, I was hoping we have more detailed description in this article about the different type of injuries we can see at functional seizures and more robust numbers. But I think it's important kind of to think that we know, and it's more like be shown here that we have a risk of injury with functional seizures. Now, speaking of functional seizures and basically injury, this is an older study from about 4 years ago, from 2020, and this was by the let me see here. All right, so we have a question in the chat. Any data on CPK and lactate and these cohorts with functional seizures? I did not see that in the study, no. So basically, the other article is it's a study done. It's basically more of an ILAE report by the Task Force on Psychogenic Non-Epileptic Seizures about driving a motor vehicle accident with patients with psychogenic or functional seizures. So basically, the methods they looked into the phase 1 was they did a systematic literature review about this topic, and then they collected some international expert opinion using a survey. And the phase 3, they had joint analysis of the findings from the survey and from this literature review. And basically, they refined the conclusions by all participants using email. And the ILE report, they send their findings to the Psychiatry Commission for review. So basically, the conclusion from this study here, or like this, or the proposal from this study is basically they reviewed the history of, they suggest this decision-making process. So when you have a patient with functional seizure, you review the history and semiology, and or actually first before you have before you make the diagnosis, if you have a concern that they might have both epilepsy and functional seizures, you would do a video EEG recording, and if basically that you record like seizures, epileptic seizures, or the study was inconclusive, or if you don't have the capacity to do the EEG, you abide by the local regulation for epilepsy and driving. Now, if you establish the diagnosis of epilepsy alone, you may apply the rules by the local like for driving and epilepsy to patients with functional seizures. But basically, the majority of expert opinion views regarding of patients with functional seizures and driving, you would move. So basically, would ask this question: has the individual experienced functional seizure within 6 months of assessment? If no, you can allow driving of private non-commercial vehicles. Sorry. And now, if they've been having seizures or functional seizures within 6 months of assessment, you would ask these questions: have the patient or like the functional seizures been associated with any of the features of the following features: loss of awareness or responsiveness, or history of injuries, or semiology likely to disrupt driving? If yes, you would ask the other question: have any of the following features been consistently present for a period of 12 months or more? And these are like the functional seizures occurred exclusively at times when the patient could not be driving, or if the functional seizures occur exclusively in response to specific triggers which could not be encountered when driving. And if you have a sufficient long prodrome warning signs to stop the driving if the events happen? If yes, you can allow to drive a private vehicle. Now, if no, if any of the answer is no to any of these questions, you would go with the with basically the local seizure precautions for driving. Now, if the answer is no for the other questions of loss of awareness or irresponsiveness, history of ictal injuries, or semiology likely to disrupt driving, the next question you should ask if the semiology has been stable. Because many of these patients, they could have a variable semiology, new type of events. But if it's been stable for more than 12 months, then you still can allow driving. But if not, then you would recommend to abide by the local restrictions on driving. All right, so I think I'm going to stop here and allow the time for some discussion. There was a question here. This location is more frequent associated to seizures. Any location of this location for epileptic seizures? Is this your question, Dr. Perez? To my knowledge, it's basically shoulder dislocation with epileptic seizures. I'm not sure about dislocation with functional seizures, so I cannot really comment on that.
Thank you. May I ask a comment?
Yes.
This is Hunter Perez from Ottawa. So you mentioned in the systematic review that they consider also dislocation as part of the study, but did they mention what specific kind of dislocation was associated or not?
Dislocation.
Yeah.
They did not, and when they reviewed the studies, there were not much of patients with dislocation. The main findings were tongue biting, oral injuries, a few burns, a few fractures, but they did not really. I don't think I went over a dislocation.
Yes.
Yeah.
Yeah, I saw the image. They say only one
Mhm.
shoulder dislocation.
Mhm. They did not really. They did not really specify details on that. And I did not see a shoulder dislocation specifically mentioned. So in general, I mean, any comments on driving and functional seizures? I mean, typically we tell our patients to abide by the rules that apply for functional seizures. I mean, for epileptic seizures. I don't know if anyone would like to comment on this proposed algorithm.
Dr. Maki, oh, sorry.
Yes.
Yes. Okay. You're muted. Okay. So I wanted to ask, it seems like the percentage, the prevalence of ictal injuries, whether it's functional seizure or epileptic seizures, it's almost the same, right? Like 25%,
Functional or epileptic?
which is interesting to comment on, I believe.
You mean in the graph? Let me go back. I don't
I think
think
you mentioned it in the beginning, at the beginning of your presentation.
that functional seizures and epileptic have the same risk. You mean this one?
Sorry?
Now, can you repeat the question? Maybe I
Yeah,
misunderstood.
yeah. So I was interested in seeing that the percentage of ictal injuries in functional seizures and in epileptic seizures, it looks like it's similar, around 25%. Is that correct?
I don't think I mentioned that.
Or the prevalence.
The prevalence of functional seizure injury, like
of injuries in functional and in epileptic seizure, you said it was around 25%.
You mean in the
this...
mixed group with patients who have both?
Yeah.
It's
You didn't have they didn't compare to like pure epileptic seizures?
no, that's the
Oh,
thing.
okay.
They did not. So that's one of the limitations. They did not compare. So they had groups with functional seizures only, patients who have functional seizures and comorbid epilepsy. So they had both. Yeah, but they did not really have
Oh,
a
okay.
group that had only epileptic seizures. So that's one of the limitations actually, because like
Would
they
have been interesting.
when you combine patients who have both, you wouldn't know exactly the injury, whether it happened from a functional seizure or from an epileptic seizure. So they
Yeah,
did
exactly.
really compare. Yeah,
Sure. Thank you.
of course. All right. So the CME code is here. Oops. I think I kind of moved it. It's souffle.
Yes.
You can text it to the number on the screen.
Yaman, do you agree on the last algorithm regarding driving from
I-
your experience?
I actually, yeah. Sorry, go ahead.
Yeah, no, just tell me what you do in your practice.
I don't go with this. I think it's I typically go with the regulations for each state based on like the same as we apply for epileptic seizures. I think many of the patients, at least that I see, they're not well controlled. Many have like a reported alteration of awareness, and they have lots of fluctuation in the number of seizures that like the frequency that happens. I typically go by the regular uh, uh, seizure, like for epileptic seizures. So like I go by each state's law.
But you do, I
Mm.
mean, you give the same restrictions to functional seizures like you do with epileptic seizures in terms of the duration according to the state.
Yes, in general.
I have to admit, I don't do that.
Mhm.
I mean, I sort of individualize and please, anybody who has a take, maybe I'm not doing the right thing, but I tend to individualize the recommendations. There are patients that I feel that, from the semiology as observed in the epilepsy monitoring unit, that the semiology suggests that these individuals could get hurt if they happen to be behind the wheel. So I tell them to refrain from driving, but others that I trust, they will be able to pull over or that they won't have it while driving. You know what I mean? And again, I'm not relying here on an affable science.
Mhm.
It's just the semiology and the depth of the insight and other factors. But perhaps I should be more systematic.
I mean, I think maybe I'm being a bit overcautious in this situation more, and because many they just have, like if you go to the last part here in yellow in this algorithm, it says like, has the semiology been stable for a period of at least 1 year? So many they have fluctuation in semiology, I believe, and it might be a bit difficult to differentiate unless they've been really consistent for a prolonged period of time, but with the same semiology. But I go with the cautious side, and unless they have simply like sensory or some mild motor manifestation that don't really affect their driving, like you mentioned. But in general, patients who have alteration of awareness, or if they have reported falls, which is most of them, at least the one I've seen, I recommend that they go by the law. I don't give them all the other seizure precautions like the alcohol restriction or obviously the sleep deprivation. Obviously, it's not good to be sleep deprived, but I stress more on the more physical seizure precautions plus the driving.
Mm-hmm.
But definitely I also individualize, but in general, that's what I do.
But it sounds like this is what this algorithm is recommending,
Mhm.
Mohammed. It's kind of what you do.
Yeah. That's right. Yeah.
Except it doesn't specify, it's not according to different states, which is interesting.
That's from the ILAE, so maybe that's why the numbers are a bit different. Yeah.
Right.
Dr. Guru, I'm gonna send you my email so we can try to fix that. All right. Any other comments or questions?
Thank you so much. This is
Of
a
course.
very important topic. Very, very nice. Thank you.
Of course, thank you for listening.
Thank you so much.
Comments, of course. Have a nice day.